Hello, everyone. My name is Amisha Kumar, and I am a high school student research intern with the University of California, Irvine in the United States. Today, I will be talking about my abstract regarding cerebral amyloid angiopathy and related clinical comorbidities in individuals with Down syndrome who have Alzheimer's disease. Before we proceed, I wanted to point out that this work was supported by the following grants from the National Institutes of Health in the United States. The 3 grants are listed on the slide. I also wanted to acknowledge all the people at UCI who helped me put this research together, especially Eric Duran, Dr. Elizabeth Head, Dr. Alessandra Martini, Kate Kirby, and Sierra Wright. I could not have done this research project without them. Before we go into my specific hypotheses, I wanted to talk about Alzheimer's disease and Down syndrome. So in Down syndrome, we see the overexpression of the amyloid precursor protein, or the APP gene, which is located on chromosome 21. And that causes the excess deposition of beta amyloid in the brain. So basically, this protein is building up at abnormal levels in the brain. And this factor contributes to the development of early onset Alzheimer's disease in individuals with Down syndrome, as the majority of these individuals will show the same neuropathological changes, these beta amyloid plaques, the neurofibrillary tangles that are seen in Alzheimer's disease in neurotypical individuals by the age of 40. So it's coming much earlier. So having established that, I want to talk about cerebral amyloid angiopathy, which is a common vascular condition in individuals with Down syndrome who have Alzheimer's disease. So these 2 pictures are showing what specifically CAA looks like in the brain. And you can see that while there are these large beta amyloid plaques, these circular areas, you can also see these blood vessels, which have a lot of beta amyloid built in them. And that is essentially what CAA is. It's the buildup of beta amyloid in these blood vessels in the brain. So the reason that this happens in Down syndrome especially is because the overexpression of that APP gene that we talked about earlier that was causing this increase in beta amyloid in the brain, it also causes an increase in the amount of beta amyloid deposited in these blood vessels, which exacerbates CAA. It makes it more likely for individuals with Down syndrome to have it, and it makes it more likely that when they have it, it's going to be severe. So CAA is also often associated with microhemorrhages in the brains of people with Down syndrome, basically because this protein weakens the walls of the blood vessels, which causes them to rupture. So one thing that we wanted to point out just straight away was that you can see that as age increases, the severity of CAA also increases, which you can see in terms of, especially if you look at the none and the severe categories of CAA on this slide. So one final thing that we wanted to discuss was seizures in Alzheimer's disease and their relation to CAA. And the reason we wanted to discuss that was because this was one of our central hypotheses for the specific research that we were doing for this project. So in a prospective study of individuals with Down syndrome and dementia, as many as 84% of them develop seizures. So seizures are fairly common in individuals with Down syndrome who have developed Alzheimer's disease. They usually show up in the middle to late stages of the disease. But the telling point here is that in a mouse model of Alzheimer's disease, the elevated levels of APP and beta amyloid made these animals more susceptible to becoming epileptic. And so given that there's this connection between this buildup of beta amyloid and developing seizures, we thought there could be a connection potentially between seizures and CAA in terms of having seizures being related to an increase in CAA severity. Before we go into the hypotheses, I wanted to discuss our methodology really quickly. So we collected clinical and neuropathology data for 40 individuals with Down syndrome who had Alzheimer's disease out of a total of 51 individuals for whom we had partial or full data. Clinical data for the majority of our participants was collected over a 20-year period as part of a longitudinal research protocol at the Alzheimer's Disease Research Center, the ADRC, at UCI. However, for some of these individuals, we performed a retrospective chart review of their medical records for the patients at the Alzheimer's disease and Down syndrome memory care clinic at UCI. However, for all of these individuals, we had neuropathology data, especially the presence and the severity of CAA, which was our main neuropathological variable. And this was recorded using the guidelines of the National Alzheimer's Coordinating Center, NAC, from the United States. Looking at our sample, I wanted to describe some of its characteristics. And I'm not going to go into everything on this table, but I do want to point out some things of interest for us. So the average age at death for our participants was about 56 years old. And the average age of first concern, which is basically when they first started showing signs of having Alzheimer's, was about 50. So the duration between those two time periods, when they first started showing some signs and their age of death, was about 6 years. So that was our duration of course. That's how we defined that. Another thing to point out is we actually had a pretty even number of males and females, which helped. Most of our participants were Caucasian, with very few in other races or ethnicities. In terms of premorbid levels of intellectual disability, most people were in the mild to moderate range as opposed to the severe to profound range. So that was definitely something that might have affected our results. In terms of karyotypes, we had one partial trisomy 21 mosaic case. And this case was very special because he didn't have a replication of that APP gene. And so he actually didn't develop Alzheimer's disease dementia. So for the purposes of our investigation, we somewhat disregarded this case simply because it was an outlier. And then in terms of dementia status, we had 43 people who either had Alzheimer's disease or mild cognitive impairment, and 7 people, excluding our partial trisomy case, who did not have Alzheimer's disease. So now that we've established that, what we decided we were going to do was we took those clinical comorbidities, these clinical characteristics that we were observing, and we broke our population based on Alzheimer's disease status. So looking first at seizures, which again was our main hypothesis, of the 43 people who had Alzheimer's disease or mild cognitive impairment, about 75% of them had seizures also, and a quarter didn't. Whereas for all our non-AD individuals or participants, none of them had seizures. So that was definitely a sign that maybe we should look into this connection between seizures and CAA, or just seizures and Alzheimer's disease in general. As for the rest, hypothyroidism, it wasn't exactly even, but it was fairly close between our group with Alzheimer's and our group without Alzheimer's. In terms of hypercholesterolemia, again, it was pretty even. It looked as though the people without Alzheimer's actually had a little bit of a higher percentage of them had hypercholesterolemia. But again, it wasn't anything that we could make any conclusions on. And in terms of hypertension, only one person overall in the entire data set had hypertension. So that was definitely a variable we weren't able to consider. As for average age of death, they were fairly even. There was a 3-year difference between those who had Alzheimer's and those who didn't. But again, it wasn't anything that we could specifically call out as saying one group was necessarily living that much longer. So finally, what we did was we broke this up such that we broke up cerebral amyloid angiopathy such that we had split it between those with Alzheimer's and those without. In terms of mild CAA, that seemed even between both groups. There was a higher percentage of people in the non-AD group without CAA. And a little bit surprisingly, there was a higher percentage of people had moderate CAA in the AD group versus the non-AD group, although it was pretty much even for severe as well. And so that was definitely interesting. Nothing really jumped out immediately for us there. So the first hypothesis we looked at was CAA and seizures. We predicted that individuals with seizures would have increased incidence and severity of CAA as compared to those without seizures. And that was just because seizures increase APP expression, which we believe would in turn increase a beta amyloid deposition in cortical blood vessels. So then we would see more beta amyloid in these blood vessels in the brain. So what we did was we created these figures seen on this slide, and this was for all the individuals in our sample, including the people who did not have Alzheimer's disease. But what stood out especially over here is looking strictly at CAA status. You can see that of the people who had seizures, a vast majority of them had CAA as well, as compared to those who didn't. And so that definitely stood out to us as being potentially promising. Although when we looked at CAA versus CAA severity versus seizures, it didn't appear that there was any unified trend. It increases, but then it decreases. So we decided to also do it with just the individuals with Alzheimer's disease. So that was our 40 individuals from before. And it just makes that difference very clear that of the people who had seizures, the vast majority of them had CAA present as opposed to absent, even though severity wasn't as conclusive. So the next hypothesis we looked at was CAA versus age of onset, or that age of first concern that we described earlier. And we said that individuals with CAA would have an earlier age of onset for Alzheimer's disease as compared to those without. And our reasoning for that was that CAA is associated with increased neurodegeneration. So we believed that we would see Alzheimer's appear early because of that earlier neurodegeneration that was being caused because of CAA. But the thing is, when we actually put this on a graph, we couldn't see any significant difference, even in the graph, between those who had CAA absent and those who had CAA present in terms of age of onset. The error bars are overlapping. There isn't a significant difference between the medians, so there wasn't much to say here. We also broke it by severity, and while it looks like there is this slight increase just in terms of the mean for mild to moderate to severe CAA, there really is no unified overall trend. The error bars are overlapping. Again, we couldn't make any conclusions. So another hypothesis we looked at was CAA versus the duration of Alzheimer's disease course, that point between the first concern and the age at death. And we said that individuals with CAA would have a shorter duration of course for Alzheimer's disease as compared to those without CAA. That was because, again, if CAA is associated with all this neurodegeneration, we believe they would go through the stages of Alzheimer's disease faster, which would mean that this duration of course would be shorter. But again, when we graphed it strictly based on CAA being absent or present, there wasn't a significant difference. So we also tried to break it by severity. And here, it seems like there is a slightly more of a trend. It seems that as CAA severity increases, the duration of course is decreasing, but we're not sure that we could draw any conclusions off of this strictly because there is such a wide spread for everybody in these categories. We also looked at CAA versus ApoE, and we basically said that individuals with the ApoE E4 allele would have an increased incidence and severity of CAA as compared to those who didn't have the allele. And that was because the E4 allele is associated with this increased amyloid beta burden in the brain. So we thought that there would be a higher likelihood that it would be deposited in blood vessels and we would see more severe CAA. The point here is when we graphed it, similar to seizures, we saw this very large difference in terms of CAA presence and absence, in terms of the fact that those with the E4 allele, the vast majority of them had CAA present as opposed to absent. And while it's true that even without the E4 allele, there was a higher number of individuals who had CAA present, the percentages are nowhere near the same. As for severity, again, we see more people in the moderate to severe range of CAA severity if they have the E4 allele as opposed to if they don't. So that definitely stood out to us. Finally, we looked at CAA versus sex, and we said that males would have more severe CAA as compared to females. The reason for that was there isn't really a conclusive answer to this particular hypothesis out there. A lot of papers contradict each other, but we decided to go with this paper by Shinohara et al., which suggested that males experience more severe CAA as compared to females. And although this was in neurotypical individuals only, we predicted the same thing would happen in individuals with Down syndrome. But as you can see by these graphs, it was actually fairly even. There was no real conclusion to draw because it was males and females seemed to have about the same percentage of those with CAA and those without. And the same was true for severity. So in terms of overall results, although a greater percentage of individuals with seizures had CAA as compared to those who did not have seizures, the presence of seizures didn't appear to impact the severity of CAA. And there wasn't a statistically significant relationship between CAA status and age of onset, nor was there one for CAA status and duration of AD course. Although the duration of AD course did appear to decrease as CAA severity increased, we did not get any conclusive results. Finally, while the majority of individuals with the E4 allele experienced moderate to severe CAA, with relatively few individuals with mild CAA or no CAA at all, our sample size was too small to draw any definite conclusions. So overall, we did not find a significant correlation between seizures and the presence of CAA, or between the severity of CAA and the duration of Alzheimer's disease course. Now, our study was limited by the fact that we had a limited number of individuals without CAA or without seizures as compared to those who presented these conditions, which meant we didn't have an equal enough group size for both to compare. We are hoping to partner with other labs in the future, however, so we can build a larger sample and potentially investigate these hypotheses once more. These were our references. I really appreciate your listening. Please feel free to pose any questions. I welcome those.